Dr. Shiv Saidha is a professor of neurology in the Division of Neuroimmunology and Neurological Infections at Johns Hopkins Hospital. The relationship between the visual system and MS has been one of the prominent highlights at ECTRIMS this year. Dr. Saidha, what makes the relationship between our visual system and multiple sclerosis important to understand?
First of all, thank you for taking the time to talk to me. I'm always interested in talking about the visual system. So, as you may know, acute optic neuritis or inflammation of the optic nerve is the initial manifestation of MS in about 25% of people. It occurs in up to 50% of people with MS at some point during their disease course. But I think more relevant than that, the optic nerve is almost ubiquitously affected as part of the MS disease process. So when we look at post-mortem analysis of brain tissue, almost all people with MS have got demyelinating plaques within their optic nerve. So that means that this is a phenomenon that is kind of ubiquitous as part of MS. And therefore, by having a high predilection for affecting the optic nerves, we're able to get a lot of insight into the MS disease process. I think, importantly, over the last number of years, we've shown that what we actually detect in the optic nerve, as measured through non-invasive imaging techniques such as optical coherence tomography or OCT, actually reflects global aspects of the MS disease process. So it really is a window into the MS disease process.
And to that point, yesterday at ECTRIMS, revisions to the way that MS is going to be diagnosed around the world were announced. One of the changes involves the role of the visual system in diagnosing MS. Can you explain what that change is all about?
Yeah, sure. So, I think up until now, the optic nerve hasn't actually been recognized as a distinct topographical region. What do I mean by that? The current dissemination in space criteria, or the pre-existing dissemination in space criteria, looked for involvement of two or more of four distinct topographies, and that was periventricular, juxtacortical, infratutorial, and spinal cord regions, with the optic nerve not being recognized. Now, when there's optic nerve involvement, whether it be clinically through the process of optic neuritis or subclinically as detected by a number of different techniques, which include OCT, visually evoked potentials, as well as MRI, it will be two or more out of five distinct topographies, and that will hopefully help to result in an earlier diagnosis of MS and, importantly, then allow people who do have MS to get on treatments faster.
Earlier and perhaps more accurate as well.
Oh, we would hope so. And I think that there's already been quite a lot of study done by the International MS Visual System Consortium and a number of investigators in particular. So Rachel Kenny, Laura Balzer out of NYU, but then also some of our European colleagues. So Gabriel Bastet in Vienna, Olivia Oitruck in France, and then also Angela Vidal in Barcelona, showing that the addition of the optic nerve into the 2017 diagnostic criteria actually does improve diagnostic accuracy. So I think you're right about that, John.
I've heard you allude to the fact that the optic nerve is the window into what's happening in our central nervous system. So with that in mind, it's been observed that thinning of the retinal nerve fiber occurs in people with MS, regardless of what other symptoms they may or may not be experiencing. What might this mean when it comes to diagnosing MS and perhaps even being predictive of disease progression?
So that's a great question. So there's a number of different OCT measures or optical coherence tomography measures, and the kind of conventional one that we used to put a lot of focus on was the peripapillary retinal nerve fiber layer thickness, in other words, PRNFL thickness. So that's the thickness of the retinal nerve fiber layer around the optic disc. That's the area that tends to be thickest. It just like in terms of like a brief, like what is all this RNFL stuff? These the cables or wires that sit in the top layer of the retina, which is the retinal nerve fiber layer, they sweep across the retina and they coalesce at the optic disc to form the optic nerve. So that's the origin of the optic nerve. And then the cell bodies, the neurons from which those axons are derived, are called ganglion cell neurons. And they sit in a layer immediately below the RNFL. It's called the ganglion cell layer. But we can assess the composite of the ganglion cell layer and the layer underneath it called the interplexiform layer. That's called the GCIPL. And the reason I bring that up specifically is that the GCIPL may have a higher level of reproducibility and reliability than the RNFL. And in a lot of the more recent studies that have been done over the last kind of like 6, 7 years, it's been shown that the GCIPL is probably superior to the RNFL in terms of its correlations with visual function, expanded disability status scale scores, brain atrophy metrics, and predictive utility of disability accumulation over the subsequent 5 to 10 years. So if we go back to your kind of like intro question about the optic nerve, if we do an OCT on somebody the very first time that they present with possible MS, not only does the OCT potentially help us with making a diagnosis of MS, it may actually have prognostic utility and feed into the treatment algorithm. Now, there's a little bit more work that needs to be done on that side of things, but I think that's also the way we're going because the GCIPL thickness is a neurodegenerative measure.
Well, speaking of the way we seem to be going, earlier today, you gave a presentation on the use of optical coherence tomography angiography in demyelinating disease. Optical coherence tomography angiography is a mouthful. What does it mean, and how might it be helpful in diagnosing or treating MS in the future?
Well, first of all, we can make it less of a mouthful by saying OCTA, because that's what the abbreviation is. I think as enthusiastic as I am about OCTA, it's a very new technique. And I did allude to this in my presentation today. While it's interesting and it's fascinating, and we're seeing very interesting relationships with disability metrics. So the OCTA may actually even have stronger correlations with disability than OCT. And it also seems to give us information or insight into levels of global brain metabolism. That's a separate study that we've been doing. It's still very much in its infancy. And it's really not ready for mainstream use. It's way behind OCT. Not only are we missing a lot of the studies that need to be done in terms of showing that it has any utility in diagnosis, I think we're very far from that because the technology right now lacks some consistency between different OCT manufacturers. So the platforms are different. The way that the metrics are being derived is inconsistent. And there's a big problem with quality control. So in our studies, about 20% of the OCTA scans, when we manually quality control them, they have to be discarded because they don't meet the QC criteria. Again, this is something that the IMS Visual Group have been working on, and my colleagues in Munich in particular, Benjamin Kinnear has done a lot of work on this. So we've done some work on this as well at Johns Hopkins. But it is not ready for mainstream use just yet. It's still very much in the research realm.
Well, Dr. Shiv Saidha, I want to thank you for all you do to improve the lives of people who are living with MS. Thanks so much for talking with me today.
Thank you so much for having me, John. It's always a pleasure to talk to you.
This conversation is made possible through a generous grant from Sanofi.